My dear students, in this video, I'm going to discuss about certain features of cardiac dysfunction in the ICU. We know that in any healthy person, sudden cardiac death is a nightmare because we hear a lot of stories about celebrities dying due to sudden cardiac death. Now, this is also very important in the ICU patients that if a patient is having cardiac dysfunction in the background, that can largely influence the course of his illness for which he is admitted in the ICU. We will see how in the next few slides. So, cardiac dysfunction is important in the ICU for largely for a number of reasons. The first and foremost being that if we are unable to recognize cardiac dysfunction early, shock resuscitation becomes blind and potentially harmful. Because we know that the two main pillars of shock resuscitation are the fluids and the vasopressors and the ionotropes. So, unless we are able to recognize cardiac dysfunction, we may end up giving a lot of fluids than the heart can actually withstand in the face of cardiac dysfunction. And that can give rise to a catastrophe. Likewise, if we are not aware of the cardiac dysfunction, we can end up giving up a lot of vasopressors and inotropes, which can lead to arrhythmias, and that can also be fatal for the patient. So, whenever we need a tailored therapy, this information is important to us about the cardiac status of the patient in a sick patient in the ICU. And treating the heart often restores global perfusion and prevents organ failure. So, this organ prevention of organ failure necessitates the requisite amount of stroke volume and perfusion. So, which in a failing heart or in a heart with a cardiac dysfunction is difficult to attain. So, presence of cardiac dysfunction changes both immediate management and long-term outcomes. And therefore, understanding the cardiac status helps us in optimizing the entire critical care strategy of the ICU illness for which the patient is admitted. And therefore, cardiac dysfunction can be looked upon as a systemic amplifier of the critical illness, which influences nearly every decision from fluids, vasopressors, ventilation, prognostication, etc. Now, how common is the problem? This is a fairly common problem because it can be seen in 1 out of 3 to 1 out of 5 patients in the ICU in some form. Some of them may be less severe, mild, or moderate. Now, among the ones which are usually observed, large number of them is actually sick, that is sepsis-induced cardiomyopathy. A good number of them is because of right ventricular dysfunction, particularly in patients with ARDS or pulmonary embolism. In patients after cardiac surgery, post-infarction, in myocarditis, there can be pure cardiogenic shock. So that is the cause of cardiac dysfunction. And in a lesser percentage of patients, in a minuscule of patients, it can be a stress-induced cardiomyopathy or Takotsubo, more common in women, although it is much less in comparison to the other forms of cardiac dysfunction. Now, in many times, despite undergoing all investigations, the exact cause remains unknown or idiopathic, that is also sizable at times. But the evolution of point of care echo and modal monitoring has transformed this bedside recognition, and what was used to be difficult in 2 decades back has become very easy now because of this point of care echo, and that also helps us in guiding individualized therapy. Let us look into this case. A 56-year-old male of pneumonia presented in septic shock. Despite norepinephrine and adequate fluids, his lactate remains elevated. Bedside 2D echo reveals a dilated LV with ejection fraction of 30%, along with global hypokinesia and normal coronary perfusion. The proBNP is raised to 5,000. The troponin is mildly elevated. Now, how to proceed? Now, first and foremost, we have to remember that phenotypes are important for diagnosis. Whenever cardiac dysfunction is present or is manifest, we will have to try to understand the phenotype. For example, A septic myocardial depression that is transient, it is reversible, and often it is accompanied by low SVR because it is distributive shock sepsis. There is a vasoplasia. So the management here focuses primarily on source control and optimized perfusion. The second phenotype may be a mixed shock where there is coexistence of distributive and cardiogenic components. That is, both cardiogenic component and septic shock components are there. And these patients require careful balance of fluids, vasopressors, and inotropes. Third category of patient can be a pure cardiogenic shock, like I said, after post-infarction or myocarditis, and they may need mechanical circulatory support. And the fourth phenotype may be an RV failure dominant shock, which is associated with high PEEP of pulmonary pathology, pulmonary embolism. And in those patients, they require preload optimization and pulmonary vasodilators. So, if we are able to identify these clinical phenotypes, how can we approach in a stepwise manner? So first, as usual, in all these patients, we have to go for an immediate assessment, which should not take more than 10 minutes. The first thing is to look for ABC and perfusion. For airway or oxygenation, we set an SpO2 target of 92 to 96%. Consider HFNC or intubation if there is increased work of breathing, reduced PF ratio, or altered ventilation. We have to look for the perfusion by mapping the skin temperature, looking into the capillary refill time, mentation, urine output, and lactate. In case we suspect refractory shock, we have to confirm it. That is when the MAP remains below 65 despite fluid challenge or despite norepinephrine dose of zero point 0.1 to zero point 0.2 mics per kg per minute. Of course, excluding other conditions where we cannot give a fluid challenge beyond a permissible limit. So we confirm refractory shock. And if we confirm refractory shock, there are certain red flags. So this red flags for alternating other than refractory shock, which is if the patient is having cold clammy extremities with pulmonary edema, it is more of a cardiogenic component. New ST changes with focal wall motion abnormality. On ultrasound, we need a ischemic workup, jugular venous distension with clear lungs, with high PEEP, RV dilatation. The component suggests RV failure or cor pulmonale. So point of care echo is very important, as I said, and this has made the diagnosis much earlier and easier. So if you look into the LV, we find look at the ejection fraction is reduced. There is end diastolic dilatation, global hypokinesia, LVOT, VTI is less than 16 to 18. That suggests low stroke volume. And if the RV size is normal or enlarged, no septal D shape at the end systole that is going against dominant RV pressure overload, if those are present, that it suggests right ventricular dysfunction. Looking into the IVC, it is possible to recognize whether it is congestion, that is whether it is plethoric or collapsible, where it is volume responsive. And then, of course, looking into the valves and the pericardium, one has to exclude tamponade and severe valvular lesions. So finally, when we look for the diagnosis on the basis of all this, if we come to see a reversible global LV depression from sepsis-induced inflammation leading to myocardial dysfunction, then usually we label those patients as sepsis-induced cardiomyopathy. But we also keep it differential these other conditions like type 2 MI from supply-demand mismatch by if there is a persistent troponin rise along with ischemic changes in the ECG. We look for Takotsubo-like stress myopathy as a differential if there is echo pattern in the apical and the basal variants. We consider fulminant myocarditis as a differential if there is fever along with high troponin along with arrhythmias. This may even require an MRI if patient is stable or patient is stabilized. And in case of mixed shock, again, as I told you, there are features of both distributive and cardiogenic shock. So after we go for a quick assessment and we recognize that keep as differential, we need to understand what should be our resuscitation targets. So we target a map of 65 to 70 millimeter of mercury, though earlier studies have shown that a target of 70 to 75 to be maintained in patients with chronic hypertension or CKD. But as of now, starting from the sepsis spam to the optopress trials, none of them has found any reasonable benefit by keeping a higher map. So we keep a map of 65 to 70. We try to improve the perfusion, like if the lactate is raised, we try to set a target that the lactate is reduced by 20% every 2 to 4 hours. We try to see a target that the capillary refill time it is more than 3 seconds, then that should come down to less than 3 seconds. If the extremities are cold, we ensure that they now become warm. Mentation is normalized and the urine output is more than 0.5 ml per kg per hour. So once done, we look for echo. In echo, we target to LVOT VTI of more than 18 to 20 centimeter or a rise of more than 10 to 15% in the LVOT VTI from the baseline after the therapy with an ejection fraction with showing an upward trend. SCVO2 likewise should be more than 70%, or if you look into the CO2 gap, that should be less than 6 millimeter. Now, this should be our targets, and in order to achieve these targets, we have to follow in a stepwise or a sequential manner so that the resuscitation targets are achieved quickly. So the first step is the fluids. Fluids should be only administered if responsive or tolerated. And especially if the patient is having cardiac dysfunction, it is always good to err on the lower side. That is, don't give excessive fluids. So if the IVC is small, collapsible, or the VTI variation is more than 15%, we give 250 ml of balanced crystalloid bolus over 10 to 15 minutes with echo, and we look for the VTI and the improvement. We can also look for the pulse pressure variation or stroke volume variation in case we are having a flow track, but there are certain limitations. That is, the patient has to be ventilated within high tidal volume. Then the patient should not have tachyarrhythmias. The patient should not be on spontaneous bleeding, spontaneous breathing, etc. So once we know that patient is not responsive, we have to stop the fluids. If the jugular venous pressure is rising, if new B lines are appearing, if there is worsening of oxygenation, if the VTI fails to rise more than 10%, or if the RV starts dilating, if you look into the echo, then we have to stop the fluids. The step two is the vasopressor. Now, vasopressor is backbone in patients with cardiac dysfunction. We titrate norepinephrine to target a MAP. The common range is 0.05 to zero point 0.5 mics per kg per minute. Whenever the norepinephrine required is more than 0.25 to zero point 0.3 mics per kg per minute, we add vasopressin. The vasopressin dose of 0.03 units to 0.04 units per minute, which is a fixed dose. It doesn't vary with the weight of the patient. We consider epinephrine only if profound hypotension with low cardiac output, and we need to combine pressor with inotropy. Of course, we need to watch for lactates and arrhythmias because both of which tend to rise following the use of epinephrine. Now, in step three, after this fluids, vasopressor, inotropes, we look for inotropy for low output sepsis induced cardiomyopathy. If there is low stroke volume, low SCVO2, persistent hyperlactatemia despite MAP at the goal, then we know that we have to improve the stroke volume. So you have to target the perfusion. So it is dobutamine, which can be started as 2.5 to 5 mics per kg per minute. Of course, there should be the risk of arrhythmias should be there, and one has to take necessary precautions. And after starting dobutamine, and we can keep on monitoring the heart rate, the ectopy, the MAP, and the VTI, and slowly we can keep it increasing. And if desired response is obtained in 60 to 20 minutes, that is within 2 hours, with an increase in VTI of more than 10 to 15%, increasing SCVO2 to over 70%, fall in the lactate, stable MAP, then of course we can accordingly titrate the dose. If tachyarrhythmia develops or if the MAP drops with dobutamine, we have to reduce the dose and reinforce norepinephrine or add vasopressin if we had not started. Alternatively, we can give milrinone 0.125 to 0.25 mics per kg, but we should avoid bolus and also adopt caution in patients with AKI and hypotension. Levosimendan similarly can be given in a dose of 6 to 12 mics per kg over 10 minutes and then 0.05 to zero point 0.1 mics per kg per minute over 24 hours. Again, nowadays we skip the bolus, we contain the confusion because of the risk of hypotension. In the step 4, we have to go for heart rate control. We know that in all such patients, high heart rate increases the oxygen consumption, and this might predispose the patients to become there can be a mismatch in the oxygen supply demand ratio, giving rise to ischemic changes. So if heart rate is more than 110 to 120 with good BP on norepinephrine with or without dobutamine and evidence of impaired diastolic filling, we on all in only in such conditions we can consider ultra short acting beta blocker like esmolol 25 to 50 mics per kg per minute. We can give ivabradine also, although the amount of evidences is more with esmolol, but we have to ensure that cardiac output is adequate by looking into the VTI, SCVO2 or an improvement lactate, and we stop if the MAP falls or the VTI falls. Now, what to check and when during monitoring? At 30 to 60 minutes and after any change in the dose of fluids, vasopressor, and inotropes, we have to go for a mini check echo where we look for the VTI, the trend in the ejection fraction, the RV size, and the septal shape. We look into the numbers like the MAP, heart rate, look into the rhythm, SCVO2, lactate urine output, and the capillary refill time. In the lungs, we go for auscultation, and also by ultrasound, we look for the appearance of B lines or a pleural effusion. Every 2 to 4 hours until the patient is stable, we look for lactate, capillary refill time, urinary output, and accordingly titrate the medications. And daily or sooner, if the patient is unstable, we go for a full echo to document trajectory in the sepsis induced cardiomyopathy. Although we expect improvement by day 3 to 5, but and near normal by day 7 to 10 if sepsis is controlled. So the weaning strategy when improving, first we wean from the inotrope if the VTI and SCO2 are stable, SCVO2 and the lactate is falling. Then we taper dobutamine by 1 to 2.5 mics per kg per minute every 2 to 4 hours while watching the MAP and the cardiac output as surrogates. After inotrope is weaned, we wean off the vasopressor, that is once off to minimal inotrope or the MAP consistently, keeping high, maintaining the target with improving perfusion. We reduce the norepinephrine 0.02 to zero point 0.05 mics per kg per minute steps increments. And we maintain euvolemia star diuresis only if the lungs are congested and patient is hemodynamically stable. Now, there are certain times when when things don't really add up. So we will have to recognize those pivotal points. That is when there is no improvement in the VTI or the SCVO2 or in the falling lactates despite using inotropes. So in those patients, we have to reassess the preload that whether it is under or over. We have to look for hidden bleeding, occult ischemia by repeating an ECG, consider cardiology consult along with coronary imaging if there are focal ischemic lesions, RV dysfunction, then a tamponade, severe valvular disease, etc. We have to consider a mixed shock because of ongoing vasoplegia with or without myocardial dysfunction. In those patients, we add hydrocortisone 50 micrograms for 6 hourly or 200 mics per day if in case of refractory vasoplegia. If there is escalating arrhythmias when the patient is on dobutamine or epinephrine, we look into the electrolytes. We correct if there is an abnormality of potassium, magnesium, and also reduce the catecholamines and consider amiodarone if need be. In case of worsening of RV size or hypoxemia with high PEEP, we look for lower PEEP if it is feasible, evaluate for pulmonary embolism, and also consider inhaled pulmonary vasodilator. The common pitfalls and fixes are over resuscitation, which can worsen pulmonary edema and the LV compliance. And in such cases, it is important to go for VTI or PPV guided boluses and to stop early if the patient is non-responsive. Chasing BP with vasopressors while the cardiac output remains low, we will have to again look into the VTI, SCVO2 and titrate inotrope if there is low output still. Mislabeling as sepsis-induced cardiomyopathy as acute coronary syndrome due to troponin leak leading to a rise in troponins. So in that case, also we look for ischemic ECG, wall motion abnormalities, and we trend the troponin rather than looking for a single value. Ignoring RV when the PEEP is high or oxygenation worsens. So that is a common pitfall. One should be focused on an RV focused echo, reduce PEEP, and consider pulmonary vasodilators. Tachycardia left unchecked. In that case, also the supply demand mismatch is worsened. So we will have to fix it by giving analgesia, sedation, etc. Careful beta blockade only after confirming adequate cardiac output. So disposition, recovery, and follow-up, we expect the ejection fraction to normalize by 7 to 10 days if infection is controlled in sepsis-induced cardiomyopathy. Prior to ICU discharge, we repeat an echo. If ejection fraction is still persisting below 50%, we can plan a cardiology follow-up in the subsequent weeks and also counsel the patient on post-ICU cardiac symptoms like exercise intolerance, palpitation, and look for and also arrange rehab, etc. So if we look finally into the phenotypes and their features and the therapeutic focus, we see that in septic myocardial infarction, we usually find a low ejection fraction, high cardiac index, low SVR, and the therapeutic focus is towards vasopressor and inotrope balance. In mixed shock, where there are components of both septic shock and cardiogenic shock, we usually get variable ejection fraction with a dynamic preload, and the therapeutic focus is guided fluid administration with vasopressor titration. In patients with pure cardiogenic shock phenotype, in this we get a high filling pressures along with low ejection fraction, and the therapeutic focus is inotropes and possible mechanical circulatory devices. And in patients with the phenotype of RV failure, we get typical features of RV dilatation with raised CVP and low left ventricular filling. And the therapeutic focus is towards reducing the PEEP and giving RV specific support. So the take home message from this video should be that cardiac dysfunction in ICU is multifactorial. Sepsis, catecholamines, ventilator mechanics all interact dynamically to produce cardiac dysfunction. Bedside echocardiography is indispensable for diagnosis and ongoing assessment. Biomarkers provide context, but as standalone, they're not useful for diagnosis. Management hinges on optimizing the perfusion, striking fluid balance, and judicious use of vasopressors and inotropes. Reversibility distinguishes sepsis-induced dysfunction from structural diseases of the heart, and also early recognition and timely mechanical support can salvage otherwise fatal case. Thank you very much.